Dr. Yen's on as well, and I'd also like to ask Dr. Ryoma Kayono to stick his camera on as well if he can. There we are. Good afternoon, Ryoma. So Ryoma did his talk yesterday, just for the benefit of everyone else. Ryoma is based at the World Health Organization Kobe Center and is responsible for health emergencies, and particularly disaster planning and health emergency disaster risk management. So he couldn't make it yesterday. Welcome, Ryoma, and but he's joining us today in case anyone has questions. So just to give Paul a minute to get his breath back, I've got one question from the audience, and that is, again, directed to all of you, but principally to Ryoma, is where does the WHO, and particularly the Kobe Center, how does that fit in with the research agenda for COVID-19 as we move forward?
Thank you, Colin, for your question. Kobe Center is basically working on the research on the global health. Our main focus is a UHC, Universal Health Coverage, as well as the health emergency disaster management. COVID-19 is a very broad, very specific, but it's a huge research area, which includes biomedical aspects and also the social aspects, a lot of aspects. So Kobe Center is a part of headquarters, and we have a very specific focus of our research area. So we are working on the health emergency disaster risk management, which is not specifically focusing on the biomedical aspects, such as the testing or treatment, not like that. We are more focusing on the social aspects or health system. So in this context, we are working on COVID-19 too, in the context of the health emergency disaster risk management, which covers all hazards, including natural hazards and the infectious disease management, and also conflict as well. So yeah, well, this is our scope. And as presented yesterday, we are organizing a global research network and also global experts collaboration to synthesize the knowledge on the health emergency disaster risk management, what is known, what is unknown in terms of the health system response to the every kind of emergencies. That is a brief introduction of
well, that's excellent. Thank you. I mean, it re-emphasizes to me how broad we need to be in terms of approaching these aspects of emergency disaster risk management, and particularly the interaction, as you said, about the social side of things and how we interact with the public that we see. Thank you. A quick question now for our two virologists. God, it's an unusual thing for us to have access to two such distinguished virologists on a forum like this. So let me take advantage and ask both of you. How should the virology teams work with the emergency departments in future pandemics? Obviously, COVID continues at the moment, but we'll have more in the future. So things like environmental sampling, should that be a routine? And you've outlined about serological testing of the healthcare workers. Is that something emergency department staff should be doing? Dr. Yen, I'll let you start.
Sure, thank you. Yeah, I think what we have done starting from last April did provided us with useful information so far. So I think the two data sets from the environmental sampling and the serology, they do correlate very well with each other. And this, I guess, in a sense, provides good peace of mind, perhaps, for healthcare workers at the environment. So I do think such a collaboration should be continued, particularly under such an emergency.
Oh yeah, we would support that. Paul, any comments on that?
Yes, I think emergency department face a lot of different requests. So to have a test that is feasible for them and applicable to them is very important. So maybe even antigen tests, as I said, the quality varies a lot, but if we can have some evaluation and help them how to interpret and prepare for the false positive kind of a logarithm of management, that would be very important.
That's great. And another question from the audience. Thank you, Sue Locklam. And this is directed to Paul. The question is, which diagnostic method for COVID-19 would you say is the most preferred for the emergency department setting for the patients who present to the ED, or does it really depend on the scenario, symptomatic, asymptomatic? Is there a preferred option?
Well, I think for COVID-19, because the portion of asymptomatic infection is really big, so I think even in the A&E department, it's very difficult to have a approach that just relies on symptoms. I think we need to test a lot of people. It's very difficult for you to say no for testing.
Absolutely.
And then for testing, in this situation, I will only recommend PCR, not antigen. Yeah.
But do you think, for example, I mean, we've traditionally used, as you've commented on, DTS, and I know that there's been some comments recently about using DTS, for example, at the airport for the high-risk cases, and whether Hong Kong should manoeuvre itself into doing more in the way of combined nose and throat testing, swabbing, like in many other countries. And it's a difficult decision to make, given that the infrastructure, particularly at the testing centres, has been built around DTS up till now.
Yes, yes. I do have some concern about DTS as well. I think in A&E department, maybe, I'm not sure, you know better than me, whether it is feasible to have really a room that your staff can take nasopharyngeal swab publicly. If that can be done, is really the goal that you.
Oh yeah, I mean, we've got negative pressure rooms downstairs, so that makes it more safe. I think the challenge on a practical level is the amount of PPE changes that would need to be made, and it would basically tie up 1 or 2 full-time members of staff all the time when the presenting load is high, which at the moment seems to be going back up again. Time is against us, I'm afraid, so I'll bring the discussion to a halt there. But if I could just say a huge thank you to Ryoma for his talk yesterday, and to Dr. Yen and to Professor Chan for your talks today. Thank you so much for supporting our workshop. I've really enjoyed that, and we'll end the session here. And for the participants, you've got 6 minutes to run to the loo, make your coffee, whatever you want to do, and we'll restart again at 1:45. Thank you very much.
Thank you. Bye-bye.
Thanks very much.
Thank you.